Hello and welcome to JCO Precision Oncology Conversations, where we bring you engaging conversations with authors of clinically relevant and highly significant JCO PO articles. I'm your host, Dr. Rafeh Naqash, podcast editor for JCO Precision Oncology and associate professor at the OU Health Stephenson Cancer Center at the University of Oklahoma. Today, I'm thrilled to be joined by Dr. Bryson Katona, director of the Gastrointestinal Cancer Genetics Program and director of the Lynch Syndrome Program at the Penn Medicine's Abramson Cancer Center, and also lead author of the JCO PO article entitled Areas of Uncertainty in Pancreatic Cancer Surveillance, a survey across the International Pancreatic Cancer Early Detection or PRECEDE Consortium. Bryson, thanks for joining us again.
Well, thank you so much for having me. I appreciate the opportunity.
And it's exciting to see that this work will be presented concurrently with the upcoming CGA meeting.
Yes, it's been a fantastic partnership between JCO PO and the CGA IGC and their annual meeting. And for those who may not be familiar, the CGA IGC is the Collaborative Group of the Americas on Inherited Gastrointestinal Cancer. It's basically a professional organization dedicated to individuals who have hereditary GI cancer risk and focusing on providing education, promoting research, and really bringing together providers in this space from not just throughout the US, but from across the globe as well.
It's exciting to hear the kind of work you guys are doing. These are definitely interesting, exciting things. Now, going to what you have published is an area that is very evolving in the space of cancer screening, cancer surveillance, especially for a very aggressive cancer such as pancreatic cancer. Could you tell us currently what are the general consensus? I know there's a lot of differences between different guidelines or societies, but what are some of the commonalities, if we were to start there first, for pancreas cancer screening? If you're not a GI oncologist, you may not be aware that there is something with regards to pancreas cancer screening. Could you give us an overview and a background on that?
Yeah, I think that pancreatic cancer screening really is one of the most controversial areas of all cancer screening. Part of that controversy is just because all of the guidelines, the many different guidelines that are out there don't always match up with one another, which I think leads to a lot of confusion, not just for providers, but for patients who are trying to go through this, and then also the insurance companies and trying to get these screening tests covered. When we think about who's eligible for pancreatic cancer screening, it's important that these are not average risk individuals. So really, we're only offering screening to high risk individuals. And those can include people that have a strong family history of pancreatic cancer without a germline genetic susceptibility that's been identified. And those individuals we refer to as having familial pancreatic cancer. And the other big cohort is those individuals that carry hereditary pancreatic cancer predisposition. These are due to cancer risk mutations in many different genes, including many of the breast cancer risk genes like BRCA1 and BRCA2, as well as ATM and PALB2, but then other genes such as the Lynch syndrome genes, and then some of the higher risk genes, such as those leading to Poich-Jaeger syndrome, as well as FAM, which is due to CDKN2A mutations.
Thank you for that. Again, another practical question, and this may or may not be exactly related to your specific topic here, but perhaps to some extent there might be an overlap. If I get a patient from a colleague, and I see people in the early phase clinical trial setting, so many different tumors for novel drugs, and I find an individual with, let's say, lung cancer who has a pathogenic BRCA2, which is somatic. Should I be worried about pancreas cancer screening in that individual, or we haven't met that threshold yet in that circumstance?
A lot of times these variants or these genes that are associated with pancreatic cancer risk get picked up on the somatic tumor profiles. Now, whether or not those are truly germline variants typically requires the next step of referring the patient for germline genetic testing. So, I wouldn't screen or make any kind of screening choices based on a somatic variant alone. But nowadays, germline testing is so easy, so efficient, and relatively cheap that it's easy enough to confirm whether or not these somatic hits are in fact just somatic or may confer some germline risk in addition.
So from what I understand from what you've said, there's debate about it, but it's something that should be done or is important enough that you need to figure out a path moving forward. Was that one of the reasons why you performed this project through this very interesting consortium called the PRECEDE Consortium?
Yeah, that was one of our main reasons for doing this. And for those who don't know about the PRECEDE Consortium, this is a very large international, multi institutional organization really focused on reducing death and improving survival from pancreatic cancer, primarily through increased and more effective use of screening and early detection strategies. This is an international consortium. There's over 50 sites now with nearly 10,000 patients who are enrolled in the consortium. So it really is, at this point, the largest prospective study of individuals who are at high risk for pancreatic cancer who are undergoing screening. And, I think amongst all of us in the consortium, just amongst discussions between colleagues, and then, oftentimes when I see patients that are transferring their care to Penn who maybe had their screening done at another center before, what we were really realizing is that, although we all do a lot of screening, it seems that people are doing it slightly differently. And it doesn't seem that there's a real consensus approach across all centers about how pancreatic cancer screening should really be done. And it's one thing if you're comparing, okay, well, maybe in the US we do it differently than, in Europe or in other locations. But even among centers within the United States, we were still seeing very large differences in how pancreatic cancer screening in high-risk individuals were done. And so that led us to really pursue this survey of pancreatic cancer screening practices across the PRECEDE Consortium. So for this survey, we actually have 57 centers who the survey was sent out to. As you know, surveys are oftentimes very difficult to get good response rates back on, but we were fortunate to have 54 of the 57, or 95% of the centers actually get back to us about their screening practices for this particular project.
That's good to know. I hope you didn't have to use any kind of gift cards for people to respond to this survey. But nevertheless, you got the information that you needed. Could you tell us what are some of the common denominators that you did identify and some of the differences that you identified? From your perspective, it sounds like there's no established consensus guidelines. There's different societies that have different perspectives on it. So I'm sure some of what you found will probably have implications in maybe creating some guidelines. Is that a fair statement?
Definitely a fair statement. And we found some very interesting results. I think one important result is really just the heterogeneity in the consortium. And so even before we got into pancreatic cancer screening practices, we were asking consortium sites, at your particular site, who is the individual that's leading these in-depth discussions about pancreatic cancer screening? And while about 50% of the sites had a gastroenterologist leading it, about a quarter of the sites had a medical oncologist, quarter had a surgeon leading these discussions as well. And we also found heterogeneity in who is the physician or the provider actually ordering these screening tests, again, with multiple different specialties across the different sites. But really, one of the main areas that we wanted to hone in and focus on was how the different pancreatic cancer screening guidelines were actually utilized in each of the particular centers. The biggest controversial area in the field is for the gene mutation carriers, whether or not we should be requiring that a family history of pancreatic cancer be present in order for those individuals to qualify for pancreatic cancer screening. And the reason that's so controversial, let's take an example of BRCA1 and BRCA2 carriers. Currently, if you look through the guidelines, NCCN and the ASGE guidelines recommend that really all BRCA2 carriers undergo pancreatic cancer screening, regardless of whether or not there's a family history, starting at age 50. However, other guidelines, such as the AGA guidelines or the AGA clinical practice statement, as well as guidelines from the CAPS consortium, do recommend that a family history of pancreatic cancer be present in order to qualify for screening. But then we have different things for other genes. So for BRCA1 carriers, in fact, it's the ASGE guidelines that recommend all BRCA1 and 2 carriers undergo screening, whereas NCCN and the other guidelines that are out there do not recommend those individuals undergo screening. Again, this huge heterogeneity in guidelines is quite striking. And so when we assessed all the sites in the PRECEDE consortium, we found some really interesting results with respect to these particular genes. For BRCA2 carriers specifically, we found that about half of the sites required a family history for recommending pancreatic cancer screening, but about half of the sites would offer it to all BRCA2 carriers, regardless of if there was a family history of pancreatic cancer screening. Rates for BRCA1, PALB2, and ATM carriers were a little bit lower, where about a third of sites would offer screening, really regardless of whether or not there's a family history of pancreatic cancer. And for Lynch syndrome, those rates were very, very low, with only about 13% of sites offering screening to Lynch patients in the absence of a family history. But I think, we're all in the same consortium, but there's still just a lot of heterogeneity in how our own individual practices are run.
Definitely different thoughts, different practices. But from what you saw, did it matter as far as outcomes are concerned, whether it was a gastroenterologist doing the screening or it was a medical oncologist or a geneticist? Or is it a combination of all of these that actually makes the most difference?
So I think we do need to get some more information about specialty-specific screening preferences. We just had one response per site in this particular survey, and so I think we're going to need a larger sample size in order to get that data. But I think that's certainly possible, that certain subspecialties may prefer screening more aggressively or not including family history. That's definitely a question that we'll be asking in future studies.
Definitely more gift cards that will be needed as well. Moving on to another aspect of the implications for early detection. From breast cancer, colon cancer standpoint, there's health economics research that shows it saves cost in the bigger picture. Has there been anything for pancreas cancer where early detection, early identification, early treatment actually ends up saving a lot more versus detecting metastatic pancreas cancer later?
It's a great question. And of course, for any screening modality, we would ultimately want it to be a cost-effective measure. In pancreas cancer screening, the jury's still a little bit out about whether or not pancreas cancer screening is truly cost-effective or not. There have been several different studies that have assessed this. And I think in general, the thought is that it is a cost-effective endeavor. But I think most of these cost effectiveness estimates are actually related to what is the risk of pancreatic cancer in the population you're studying. And so when you have very, very high risk individuals that have over a 10% lifetime risk of pancreatic cancer, it's almost this certainty that pancreatic cancer screening is going to be cost effective. However, if you have, say, for example, BRCA1 carriers where lifetime risk of pancreatic cancer may be less than 5%, likely around like 3%, those individuals, I think it's going to be a tougher sell to say that it's cost effective. But as we get more data on pancreatic cancer screening, that will be a very important question to ask. And, when you mention how does it save money, our goal, at least in pancreatic cancer screening, is to really downstage pancreatic cancer at the time of diagnosis and allow someone to undergo, ideally a curative intent surgery. There's data out there showing that we can downstage the cancers, that survival after the time of diagnosis is substantially increased after detection in a pancreatic cancer screening program. But again, these are studies that are based on fairly small numbers of converters. And so I think we need more data in that space as well, which is one of the main questions that the PRECEDE Consortium is trying to answer with all of our prospective data.
Excellent. Well, I hope we see more interesting, exciting work from the PRECEDE Consortium at meetings as well as a publication in JCO PO. I'd like to shift gears briefly for a minute or two, Bryson, to you as an individual, your career. How have you evolved over the last 5-7 years? How did you end up doing cancer genetics? What are some of the lessons that you learned along the way and some of those that you would want to share with our listeners, especially trainees and early career faculty?
Just to give you and others listening a little bit of background, but I'm a physician scientist, gastroenterologist, but a physician scientist. And so my clinical practice is exclusively focused on individuals with hereditary GI cancer risk. I run a basic science lab where we do a lot of studies in organoids and mouse models of these hereditary GI cancer risk syndromes. And then I also have a clinical research group where we do early phase clinical trials and screening and early detection trials, again, in these same individuals with hereditary GI cancer risk. I think probably the most important thing that kind of allowed me to get to this stage in my career where I'm trying to, essentially try to juggle all three of these balls at the same time is that I absolutely love what I do. And I'm so incredibly interested in what I do. And I think for young individuals that are coming through the pipeline and going through training, finding a specialty in a clinical niche where you truly just enjoy the work and you enjoy the patients and you enjoy your colleagues is by far the most important thing. I ended up getting into the hereditary GI cancer space because a lot of my work earlier on in my career, during my PhD and then in my postdoc work in the lab, really focused on colorectal cancer. And I thought that focusing on cancer genetics could allow me to really continue to think from the molecular side of things while simultaneously being a gastroenterologist and taking care of patients with hereditary cancer risk.
Well, thank you so much for giving us a sneak peek of your journey and insights on what perhaps works best, especially when you love what you do. That's, I think, one of the most important reasons of what tries to keep you going and keep you interested, keep you passionate. So thank you again. Thank you for listening to JCO Precision Oncology Conversations. Don't forget to give us a rating or review and be sure to subscribe so you never miss an episode. You can find all ASCO shows at asco.org/podcast.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.